It gives me great pleasure to introduce the next speaker. Many of you here know Dr. Faries, and it's just been a pleasure to have a surgeon like Dr. Faries to collaborate with, not only because he does great work and good surgery, but because he's the type of collaborator that every investigator wants, someone who continues to push for the betterment of care and builds a program. In about 3 years ago, we began talking about a adoptive T-cell program at the John Wayne that could benefit patients throughout the Southern California area. And every year it was more like, when is it coming and when is it coming? Well, it's here. And I think you'll be amazed by just the amount of work that it took to bring it here and the promise of this type of therapy. So I'll step off and allow you to just get involved in this type of journey.
All right, hi, good morning. Thanks for being here. It's always been a great program, and it's an honor for me to be a part of a panel with such great researchers and clinicians. So I'm going to talk about adoptive transfer, tumor-infiltrating lymphocytes, and other cell-based immune therapies. And I'll give another sort of intro to the immune system and how it interacts with cancer. Some therapeutic uses of T-cells, and in terms of this adoptive immunotherapy, what has been kind of the standard model for how this is being done, and some of the newer modifications to that are taking place to try and make it even better and more effective. So I don't know if you remember the scene from the movie The Matrix, where the guy's looking at the computer screen, and it's just the green dots coming down. And he says, eventually, you don't even see the dots anymore. You just see the blonde and the brunette. And so we sort of have the same thing for these statistical type figures. So for this figure, we don't see the blue dots anymore. To us, this looks like a plane crash or a natural disaster. Because what this is it's a plot of the outcomes, the survivals, from all of the clinical trials, the clinical investigations that took place prior to when this was done. So this is 2008. And what the statistician has done is he's plotted these outcomes versus how big the trial was, how clear the result was. And the upshot is that anything that falls outside of these boundaries showed promise, showed something that was going to work. And you can see that nothing fell outside of those boundaries. And so it was a disaster. Basically, nothing seemed to be doing any good. Well, it's a totally different world that we live in now that you've heard about some already. And so these are some of the trials that you saw results of that have presented with the targeted therapies, with ipilimumab, the new drugs, the PD-1 blockade, the BRAF-MEK combinations, the IPI and PD-1 combinations. And so all of these are outside the boundaries. All of these have done a world of good. And I'll just throw a little shout out, since there are at least 3 surgeons in the audience, that surgery also still probably has a role for some patients with stage 4 metastatic disease. It's a different role than it probably was a few years ago, but still there. So tumor-infiltrating lymphocytes, we know, and we have known for a long time, that there is a natural ability for the immune system to recognize cancer and to react against it. And so this is just a slide, a microscopic image of a melanoma. And all these big sort of brownish cells up here are melanoma cells. And all these little guys down here are lymphocytes. They're immune cells. And you can see that they're percolating up into this tumor. And they're there for a reason. So this is not a patient that was treated. This is their primary tumor. And so these cells, these immune cells, can recognize that there's something going wrong and react to it and infiltrate in there. And this is actually a positive prognostic factor. If you see this, it means that the outlook is somewhat better than if you don't. But by definition, anyone that develops metastatic disease, whatever recognition took place, was inadequate. But we now know an increasing number of ways of manipulating this recognition, strengthening it, and leading to better outcomes for patients. And so you've seen this analogy, and I'm going to stretch this analogy kind of to the breaking point here, in terms of how the immune system works and how we can potentially control it, and in terms of steering, braking, acceleration, and ignition. So if you think about how tumors might interact with the immune system, if you have a melanoma, you might have some of the melanoma cells that die, but either from the tumor or from these dying tumor cells, antigens are released that then the immune system can recognize. There are cells in the immune system whose job it is to survey what's going on and find signs of trouble. And so those can be these dendritic cells. They can pick up these tumor antigens, and then they mature and become more effective at generating immune responses. And then they tell these, which are the worker bees, the soldiers of the immune system, the CD8 killer T cells, to go off and find these targets and destroy them. They go and find the melanoma, and their job is to kill it. And so all this, in that micrograph you saw, all that had taken place, and those lymphocytes were there, and they were trying to kill the melanoma cells. But there are various ways this system can be manipulated for good and bad, naturally and by us. So there are helper cells that can help this reaction against the tumor. There are regulatory cells that can dampen it down. And then there are other things that can affect which direction these things go. You turn on this immune system, I think, at this point with these antigen-presenting cells. So these cells take up the signs of the tumor, and they get turned on. They turn the key, and they say, we need to start doing something. You can steer this response, and I think of this, which is the lymphocyte, the T-cell. This is sort of the steering wheel. So this is what, it's the T-cell receptor, and this is what targets the cells at whatever they're supposed to do. And any particular cell only reacts to one thing, but the body does this amazing job of developing millions of different possible combinations of things for these cells to respond to, so they can respond to just about anything that exists in the world. So this is sort of the steering wheel. And then in terms of the brake pedal and the accelerator, you can think about it as happening kind of in here, where the cells are generated and then they go off to find their targets. And you can brake that. You can accelerate it with helper cells. You can brake it with regulatory cells. You can also brake it with these checkpoints that you've heard something about and you'll hear more about in a little bit. You can accelerate it with other signals or fuel for this with cytokines and other stimulation. So forward or back. So how do some of these brakes work? You've heard about CTLA-4, and so here's an antigen-presenting cell. Here's a T-cell, and the T-cell comes up. It doesn't know what it's supposed to do, but it interacts with this antigen-presenting cell. And so you can see the steering wheel here, and the antigen-presenting cell is telling it what it's supposed to go after. And then there's the second signal here that has to take place to actually turn that cell on. And there's this thing, CD28. And when you have this combination of the target and the second signal, that cell gets turned on, and then it goes off to find and kill the cells that it's supposed to kill. Eventually, it circles back around and finds the antigen-presenting cell again. But what happens this time, you still have this interaction of the steering wheel and the target, but now instead of that CD28, what's here is the CTLA-4 has been upregulated after the response. It's a natural thing, but what happens when this interaction takes place is that cell gets turned off, and it's not going to do anything anymore. So if you can block this, then you can take that brake off. So this is like the parking brake. It's not while you're out driving around town. It's when the cell's checking back in, and it either goes off to park for good or it goes back out again. And so the reason, this may be why if you've had ipilimumab or you've seen how that works, it can take longer for this to work. But if the parking brake is off permanently, that response can last potentially forever. The other brake is the brake that happens out in the neighborhood as you're driving around. And so that's the foot pedal. And so here, the T cell comes up to the tumor cell. You have that same interaction of this, the steering wheel with the target. But what can happen here is you have on the T cell this PD-1, or you can have on the target PD-L1, and that shuts down this response and turns off that T cell as well. So if you break this up, then you keep this on and you kill that tumor cell. So there are lots of ways that we can manipulate this cycle of the immune response. You can do it with various things that will accelerate this killing of the tumor. So radiation can do it. TVEC that you've heard about, electrochemotherapy that Dr. Antipaka mentioned as well, cryoablation, the rose Bengal or PB10 that you heard. So all these things can kill these tumor cells and potentially release more of the antigen. You can do things to accelerate this process, this ignition switch for the immune system with BCG, with other immune adjuvants, toll-like receptors, the GM-CSF you heard about. So lots of different options there to move this along. There's IL-2 as a fuel that you heard about, CD40 ligand, anti-CTLA-4 and PD-1. There are a bunch of different things that can come in here. And so I think you're kind of getting the sense that the immune system, manipulating the immune system is not really like driving a car. This is how the smart people explain to the surgeons how it works. It's probably more like driving a space shuttle. And we really only know a handful of these controls, but as you hear, I think in the next talk, we know more and more of these different controls, and there are more buttons we know how to push now to try and get this to move in the right direction. So, simple-minded surgeon, I like T cells as a modality to use as therapy because they're sort of more like a self-contained thing, like a cruise missile. So this thing knows where it's supposed to go. It knows what to do when it gets there, and you just fire the thing off, and it will go and find its target and destroy it. And so this is sort of my thought of how adoptive immunotherapy works. So I'll talk about that, how it works, what the standard model is for it now, and then how it's been changed. So if you have a patient that has a metastatic tumor, you can take that tumor. One of the things we know is that tumor can be recognized, as you've seen, by the immune system. These immune cells can infiltrate into the tumor, but they can't quite get rid of it. And so you can take that tumor out, and if you look at it under the microscope, you'll see that in there are these immune cells. You can stain special stains and highlight them, and all these dark things are the lymphocytes. But again, for whatever reason, they're not able to get rid of those tumors. So the other thing you can do with that tumor is take a piece of it and put it into special conditions in the laboratory that favor the growth of these lymphocytes and enable them to proliferate, grow up, and then eventually kill that tumor that's in the well. You can then take those T cells and test them still outside of the body and see which ones can actually kill melanoma cells. And those ones then you select and you put through what's called a rapid expansion protocol, which again, specialized culture conditions, these special flasks with added factors into the culture that enable those cells to grow out and really proliferate. And so you can grow up an army of these things, tens of billions of cells that then you can put in this IV bag and then infuse into the patient. And then they search out throughout the patient to find where they're supposed to go and to kill it. And so they developed these techniques at the NCI to do this. But unfortunately, what happened was even when they found these cells that could go and kill melanoma cells, when they gave them back, they all disappeared. They didn't work. They didn't really see much in the way of responses. And the problem is all the cells that they infused, basically within a few days, more or less, disappeared. So it took more work, mainly done at the NCI, to figure out how to fix that problem. And it came through what's called lymphodepletion. So now they recognize that basically the body can understand how many lymphocytes it's supposed to have, and if you dump in a lot of extra lymphocytes, it just gets rid of them. It says we don't need all these lymphocytes, and they just delete them away. But if you deplete out the lymphocytes before you infuse the lymphocytes you've created, it opens space for those cells to persist. And so in this study, they initially would infuse cells without lymphodepletion, and then basically they saw again that they all went away very rapidly. But for the second round in this planned treatment, they conditioned these patients with something called fludarabine, which is a chemotherapy, as a way of depleting out their lymphocytes, and then did it again. And what they saw was they were successful in depleting out those lymphocytes, so they went away. And the other thing that happened was that the patients secreted these what are called homeostatic cytokines, cytokines that sustain the cells and allow them to grow and proliferate after they're infused. So IL-7 and IL-15, and you can see they spike at the time when the fludarabine is given. And so these things allow the cells to persist. A very similar study from the NCI where you see the same increases in IL-15 and IL-7. Here with that same type of chemotherapy, or that combined with total body irradiation is another way of depleting out those cells. And so now, instead of the cells all disappearing, the cells persist, and they begin to see responses like this with very rapid, so extensive disease here in this scan in the liver, very rapid, in a month all the tumors are gone, long-lasting responses here a couple years out, and when you look at the overall survival for these patients who are generally fairly heavily pretreated, you can see there are more and more patients that have long-term survival after infusion of the cells. So it's not easy to do. So if it's so good, why isn't everyone doing it? And the problem is it's technically challenging to do it. It requires a lot of work to be able to have a process to grow these cells. There's actually a fairly sustained timeline, a long timeline in between when someone would sign up for this treatment and when they could actually be treated. It can be difficult to find cells that are reactive for the tumor, and the way the treatment is standardly given now, it involves high-dose IL-2, which is difficult to take. So technical challenges. So far, this adoptive therapy has been done at institutions like this one, So this is the National Cancer Institute. This is MD Anderson, as seen from space. So these are small cities, right? Memorial is the same way. Very, very big places and with capabilities that are well beyond the reach of many institutions. This is St. John's, and this is John Wayne across the street. Our little hospital, which shown to scale, is about like this. And so the question is, can a place like this, a community hospital more or less, do this same sort of thing? And as it turns out, we can. So this is the entry to our lab. This is Hitoe Takura, who runs the lab. This is on the inside. Yu-Chin Kwan does a lot of the cell growth for us, and it's not an enormous facility, but it's a clean room. It's a room with standard operating procedures that enable us to do this safely and grow these cells under conditions that will enable us to give them back to patients. It also requires a team. So we have this guy helping out too, because it's really a multidisciplinary process to be able to grow these cells and then give them back. But our IND has been approved by the FDA. Our trial is open, and it looks like we'll be able to do it. Another challenge is the timeline. So from the time a tumor gets taken out for use in this therapy, it's 2 to 4 weeks before enough cells have grown out that they're able to be useful. It takes a couple of days to test them to see if they actually respond to the tumor cells, and then a reliable 2 weeks to do this rapid expansion to be able to have enough cells to infuse back. And so that's a couple of months potentially, which for patients with metastatic melanoma is a very long time. So that's a challenge for sure. The other thing is tumor reactivity. Although we can grow cells from just about every patient, we can't always demonstrate that they're reactive against the melanoma cells. And they may just be random cells that happen to grow out, and so that's potentially another challenge. And so there have been efforts to modify this process to try and get around those problems. And that's largely with modifying the T cells themselves. So rather than taking them out from the tumor, you can get lots of T cells from the patient's peripheral blood. And so these, you can put them through a leukapheresis process, you get a huge number of these lymphocytes. And then outside of the body, those lymphocytes, these are not melanoma-specific lymphocytes, but they can be turned into melanoma-specific lymphocytes. And so you can insert in there a gene and make a transgenic T-cell receptor. And so now this receptor that you've inserted is specific for a melanoma target. So the transgenic T-cell receptors, the other thing which is actually even more commonly investigated now are what are called chimeric antigen receptor T-cells, or CAR T-cells. And here you insert a different kind of gene, and rather than having a regular T-cell receptor that's created, it's kind of a hybrid protein that's here that's a combination of a T-cell receptor looking thing on the inside, but on the outside it's more like an antibody. And that difference means that it can recognize different types of targets than this can. And so this has really been is furthest along in clinical development. The transgenic T-cell receptors have been investigated, and you can see that they infused these cells. Many of the times the cells didn't take, or they went away. Sometimes they persisted, and they actually saw in this trial a decent number of patients that had some response, where the tumors got smaller or less bright on the PET scan. Unfortunately, these were all transient responses, and so the tumors somehow were clever enough to get around the cells that were infused. And you can see how complicated this process is based on the number of authors on this paper exceeded the number of patients in the trial by a factor of 2 or 3, I think. So it's difficult to do. The CAR T cells are very far in development in lymphomas and leukemias. And those are tumor types that are maybe ideal for this type of therapy because they have very, very specific targets to attack. And so this is a schematic of the gene that's inserted into the T cell, and it has these T cell components to it, and then these antibody components to it. And here it's directed at a molecule called CD19, which is expressed on all B cells, B lymphocytes in the blood, but also on all of the tumor cells that exist in these types of blood cancers. And you can see that there's this indication from release of these tumor-related factors that the tumors are being killed. This bone marrow biopsy, which shows disease, is then within a few weeks totally populated by these cells that have gotten in, that were infused and are killing the lymphoma cells, and then eventually 6 months later the bone marrow normalizes again. And this is what's called flow cytometry. So each of the little dots on this represent a cell from the peripheral blood, and these are all cancer cells up in this corner, and this confirms that they're all cancer cells down here. And this is before treatment. A month after treatment with these cells, all of those cancer cells have been deleted, they're all gone, and in many patients this was a long-lasting response. A very similar approach from the NCI, another CAR T-cell, and really what this shows in the schematic, this is the treatment, this is the generation of the cells. So the cells are taken out, they're grown and transduced with the gene, and in 10 days, not 2 months, in 10 days they have cells that can be infused for therapy. And they saw great responses in this trial as well. There was one death that may have been treatment related, and there were several neurologic toxicities, seizures and those sorts of things, which you don't have a great explanation for why that occurred. But a high response rate, many of those responses were ongoing over a long term, and you can see this clearance of the scans and more flow cytometry with all of the cancer cells here and all gone here. The other thing, though, that this signifies is that all of the B lymphocytes, the normal cells that make antibodies in the body, were gone also. So they're all depleted as well. They eventually return, and they return probably because these infused cells eventually go away. But highly effective for lymphomas. But what about non-lymphoma type cancers? Well, there's potential danger involved here. And so these are, again, the cruise missiles that you've shot off. And they're also cruise missiles that can multiply after you've given them back. So they're potentially dangerous. And so this is a study from the NCI where they targeted at this ERBB2, which is HER2 new, you may have heard from breast cancer. One of the patients that they did this for was a 39-year-old with metastatic colon cancer. And they infused 100 billion of these CAR T cells, and within about 15 minutes, the patient had developed respiratory distress, hypotension, and within 5 days she had died. And it's almost certainly a reaction, the responsibility for this was on these cells. They just went crazy and signaled this cascade. So this is another similar example of this effect, which is on target, off tumor, because some of these targets exist not only on the cancer cells, but on other cells as well. And here it was manifest, so you see there's a response, the tumor gets smaller, but this is on a colonoscopy, the colon gets very inflamed, eventually it's settled down, but it's potentially a serious thing, and some caution is required. But there's a lot of enthusiasm for this, so not just in the heme malignancies, but also in ovarian cancer, neuroblastoma. There are natural killer type cells, other types of lymphocytes that can be used for this therapy. And this is just a partial list of different targets and cancers that are potentially targetable by this type of therapy. The most extreme example of this also comes from the NCI with a patient that had a cholangiocarcinoma resistant to multiple types of chemotherapy. And they took out the tumor, they grew lymphocytes out of it, but then they did what's called whole exome sequencing. They sequenced the genome of this patient's cancer and identified all of the mutations that were in it. They targeted a specific mutated protein in that patient's individual cancer. They found cells that were reactive to it, to that mutation, and infused a culture of about 25% purity of that, and were able to establish stable disease for this patient. They then grew more of these cells and had 95% purity of the cells that they gave back, and were able to induce what seems to be a long-standing remission for that patient. So the last problem for this is hydrocyle 2. It's a big problem. Not most patients will have a hard time with it. Many patients can't tolerate it. But can we get away with less? Can we either use lower doses of IL-2? Can we combine it with a checkpoint blockade to make it not only more tolerable, but potentially more effective for other patients? So these are the other types of explorations we can do. I won't talk about bispecifics just in the interest of time, but Dr. Hamid mentioned it, my own cartoon of how they work. They're little molecules, antibodies on either end, basically, and so they'll come and bind a target on the tumor, and then they call in the lymphocytes and bind them to, and it sticks like glue. And this isn't a melanoma-specific T-cell, it's just any old T-cell, but this gives it specificity and it releases its payload and kills that tumor. This is that synapse between the T-cell and the immune cell. So it's a complicated system. We're learning how to manipulate it. There are things that are approved that can help us move things through this cycle. There are other things that are coming along that may get approved that'll help us move things along as well. And we'll get there in raising that curve. This is always a difficult talk to sort of figure out what to say because you all have very diverse experiences with this. And some people have experienced kind of the miracles that we've seen, and it's appropriate to have this religious kind of atmosphere here because it is sort of a religious experience. But we also know that there are others here that have not had this benefit and that still need us to do better, and that's what we're trying to do. So thanks very much to the group for letting me be here again, and glad to be a part of it.